Good afternoon, everyone. Thank you for joining us today. Yate shiket do dine she Corina Sabiku Yenishe Hachini Nishle Hawathane Bashishchi Tohablini Dashache Ma Idishkini Dashanele Go Dego Dine Etsan Nishle. So this is how I introduce myself as a Navajo woman. Good afternoon, my friends and relatives. My name is Corina Sabiku. I am from the Red Running Into the Water clan, born for many Hogans. Welcome all to the second month of our relaunch of the Indigenous Health Topics speaker series. Indigenous Health Topics is focused on hosting speakers who are local, regional, and national experts in health, education, and research. These presentations will be focused on topics that have an impact on the Native American, Alaska Native communities. There will be opportunities to attend in person in Rochester and virtually. So thank you all. Our guest speaker today is Melissa Buffalo. She is the Chief Executive Officer. Ms. Buffalo is an enrolled member of the Meskwaki Nation in Iowa and Dakota from the Crow Creek and Lower Bruce Sioux tribes. She received her undergraduate degree in child psychology from the University of Minnesota, Twin Cities, and earned an MS in human development from South Dakota State University. Melissa has over 15 years of experience working in the public health sector in a variety of different roles. She brings a wealth of knowledge to ACAF as the CEO. Melissa is committed to working with and for tribal communities, both urban and rural, supporting our Indigenous people with opportunities to heal emotionally, historically, spiritually, and physically from the burdens of cancer. Please welcome our guest speaker. If anyone does have questions, feel free to leave your questions in the Q&A or chat, and we will get to them at the end of the presentation.
Thank you, Karina. You have to put it in.
Are you recording?
I think it was recording. Okay. 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 Thank you, Karina. Haomi Dakiapi, Ampetuashte, Melissa Buffalo, Imachi Apie, Nichincha Numyunke, Kanji Wakwa, Oyanke na, Meskwaki, Hematahan. Good afternoon, welcome. My name is Melissa Buffalo. I won't go into my introduction again. Karina, you did an amazing job, so thank you. So happy to be here today to talk about reclaiming Indigenous health and building partnerships to strengthen culturally appropriate cancer prevention. Before I begin, I just want to say the American Indian Cancer Foundation is located on the traditional lands of the Dakota people in Bede, Ottawa, Ottumwa, Minnesota, or present-day city of Minneapolis. Here at ACAF, we strive to live out the values of balance, sustainability, respect for all living things, interrelatedness, and lifeways rooted in culture. We acknowledge the Dakota people's continuous contributions, past, present, and future to our world. We give thanks to our earth relatives too for its generosity of life. Feel free to comment. I guess we say this for most of our presentations, but we like to see where people are joining from. I also want to say you can text 907-312-5085 and enter your city and state to find out whose ancestral homelands you reside on. You can also learn more about the Dakota names for places across Minnesota from Marlena Miles. That website will be also entered into the chat. It's always nice when I present to just give a little bit of perspective of who I am and where I come from and why I do this work. This is my dad and my three sisters and all of our children. My dad's got cancer right now. We just moved him to a nursing home. So sometimes it can get emotional when we talk about the work that we're doing, but you realize it also drives you to, improve the health and wellness of our Native people for future generations, as well as those who are currently, living with a cancer diagnosis. For today, again, the objectives of understanding the importance of building those partnerships and the work we do at ACAF. So just wanted to give a quick overview of ACAF. What is our approach to the work we do and how we do it. understanding some of the cancer inequities, providing some of that data. And then kind of, how does all of that play into understanding historical trauma when we look at those inequities? And, how can we build partnerships? What does that mean? What is the path forward and what are those next steps? So the American Indian Cancer Foundation was founded in 2009 and became operational in 2011. We are national and we, happy to say that our footprint continues to expand. All of ACAF's board members and the majority of our staff are American Indian with an array of expertise and experience serving the health needs of our people. We have 23 amazing, hardworking staff who live across 5 states. ACAF's mission is to eliminate the cancer burdens on American Indian families through education and improved access to prevention, early detection, treatment, and survivor support. And we look at this vision, right? ACAF's vision, and I think a lot of us could say we, really see a world where cancer is no longer a leading cause of death for American Indian and Alaska Natives, for all Indigenous people. And like I said, I think this vision holds true for all of us. So through hard work, culturally appropriate, community-based programs and policy change that affords Native people access to the best prevention and treatment strategies, we really do see a day where American Indian communities are free from the burdens of cancer. Again, kind of looking at that approach and really knowing that we believe Native communities have that wisdom to find those solutions to those health inequities, but oftentimes are seeking, organizational capacity, expert input and resources to do so. ACAF is here to work with tribal clinics, tribal communities, staff and various funded projects to provide the necessary and culturally tailored tools to address, those low screening rates. How do we understand those barriers and how can we, really lean in on that cultural wisdom, that community wisdom to assist in reducing cancer and increasing American Indian and Alaska Natives' health and well-being. So again, kind of getting into that, the inequities, right? Needing to understand the data. And so this is where we really need to start with data when we talk about our health issues in our Indigenous communities. And oftentimes we don't have, whether it's accurate or access to that data. And it's been a struggle across Indian country. And it's, for many reasons, most times, the data sample size is too small. Oftentimes we can see racial misclassification. And so the data shown in the chart to the right shows that for American Indian Alaska Natives, cancer death mortality rates have increased over the past 20 years, while decreasing for whites over the same time period. Again, this information was pre-COVID, so it'll be interesting to see that data in about 5 to 10 years. So again, seeing that other populations have celebrated decreasing mortality rates, in the past 20 years. So again, so what does that work and how do we really use and get access to accurate data? According to the National Congress of American Indians and Alaska Natives, are oftentimes described as an asterisk nation because we look at the asterisk in, reports, manuscripts, journal articles. And so instead of a data point, we're often displayed this way in reporting for racial and ethnic data due to various data collection and reporting issues. Again, such as small sample size, large margins of error, or other issues related to the validity and stats, or the significance of data on American Indian, Alaska Native people. So really working, again, seeing across the slides, I'll be talking about the importance of partnership and working together, for this one to really get accurate and relevant data. Around 2017, ACAF created and produced a cancer burden booklet, that really highlights cancer burdens across 6 geographic regions. We're currently working with our research team and our communications to really update and redistribute the cancer burden booklet with updated data. And so looking at what are the most common diagnosed cancers among women: breast, lung, colorectal; for men, prostate, lung, colorectal. And then looking, lung cancer is the leading cause of cancer death for both men and women. And we look at these other leading causes of cancer death: prostate, colorectal, breast. And so again, wanting to highlight other data that, we've shared. We recently shared some of these numbers at our 11th annual Powwow for Hope The 5-year survival rate for breast cancer is 90% among American Indian women. Biannual mammography rates are lower among Native women in comparison to women of other racial and ethnic groups. And as we look at cervical cancer, occurrence of cervical cancer is 56% higher among Native women in comparison to women of other racial groups, which, can reflect a higher underlying prevalence of persistence for infection with HPV and less access to less access to screening for preventative care. The 5-year survival rate for cervical cancer in Native women is 70%. Screening is low among our women who utilize Indian Health Service, with only 55% of women ages 24 to 64 of years are up to date on screening in 2017. Colorectal cancer is one of the most commonly diagnosed cancers among Native people. For American Indian people, again, it's the 3rd most commonly diagnosed cancer. And for our Alaska Native community members, it is the 2nd most commonly diagnosed. And so across the nation, the campaign is that 80% of people will be screened in every community. But among our Indigenous communities, only 56% of people are up to date on their CRC screenings. Again, understanding lung cancer, the 5-year survival rate for Native people is really different, marking significant disparities among our people. In comparison to non-Hispanic white cancer survivors, Native people survive at a rate of 46% versus 60%. Understanding that liver cancer rates are highest again for Indigenous people, and as we compare it to other racial and ethnic groups, in particularly, liver cancer rates are elevated in every region of Indian country, demonstrating a high prevalence of risk factors across the board. And then we think about cancer survivorship, right? We still know that COVID-19 continues to impact our communities and continues to be a threat for our relatives, who are immunocompromised, including our loved ones who have been diagnosed with cancer. And I say that again, and when I present, I really love to bring in, those personal connections to cancer to help you all understand the impact that we have, and again, why we do this work. And so my dad, we recently moved him to a nursing home, and within 2 weeks he got COVID. And on the way down here, I called him and he tested negative. So I was like, yay. So he gets to get out of the COVID unit. So we'll be going to visit him, which is exciting. So again, we think about the impact of COVID still having on a lot of our relatives who have a cancer diagnosis. Again, I just want to highlight, we know that cancer is the #1 cause of death for women and the #2 cause of death for men. You see heart disease and unintentional injury in there as well. Just again, highlighting, our cancer burden booklet really shows the distinct patterns across 6 geographic regions. Again, these are defined by Indian Health Service. So just using those as our preface as this book was built. And again, our hope is to really update and redistribute this book within the next 2 to 3 years. And so how are we looking at it right now? What are we doing to update that information? And so we really want to identify, what are those current data sources? What is out there, what's relevant? How can we work in partnership with other systems, entities to get that data, right? Get the data. We want to then evaluate those data sources, understand them, see what the story tells, and then we'll select and compile relevant and appropriate data sources. Really planning and designing what that will look like. And as we analyze that data, we really want to help interpret the results, right? Be a storyteller, tell a story, tell one that resonates with our tribal communities. We want a story that doesn't bring harm, but is valuable, current, and relevant, and has information that our tribal leaders and decision makers can use to implement change, again, to get back to that health and well-being of our Native communities. And then we wanted dissemination, right? We want to disseminate that data once we've analyzed it and created a story, right? And then again, who are we sharing that with? How are we sharing that data? And again, asking ourselves, why are we sharing it? what is the purpose of dissemination? We want to be able to give it back to our communities so they can use that information to make informed decisions, and being very intentional with that data, right? This is data is a story of individuals. And we want to be able to, use this model, but we also want to know that there's opportunities that we can challenge that data, and be able to have conversations with it. And so there's really a critical need for accurate, meaningful, and timely data collection in American Indian and Alaska Native communities. Again, understanding, why we do this work and why we're all here in this room today or in this Zoom meeting. And so right, we get that data, also understanding what are those root causes of chronic disease, being able to use that as well in the storytelling. And so in order for our Native communities to achieve that full health potential, we also need to acknowledge and understand those adverse social determinants of health that have hindered our ability to achieve health equity as Indigenous people. These social determinants of health include historical and intergenerational trauma that was passed down through colonization, genocide, stress, disruption, in child development, poor access to healthy foods, services, employment, education, and transportation. Many of these adverse social determinants of health really lead to a cycle of adverse childhood experiences such as household dysfunction, abuse, neglect, right? And then we know that these experiences often lead to that behavioral risk factor. Again, that lack of, physical activity, unhealthy eating, commercial tobacco use, and addiction. And then we know these behavioral risk factors ultimately lead to poor health outcomes and an early death. But right on the flip side, right, we can take all of that, and I'll go back to some of those traumas and those determinants of health. But we also, all of us that do this work have an opportunity for our relatives to really achieve their full health potential through partnerships, right? By bringing work that balances our health. And we know that there's so much work and effort out there to come back to our traditional foods, understanding the balance with commodity food, because it is still there, it's still being distributed, or the love that American Indians have for fry bread. Our ancestors were hunters, gatherers, they knew when and where to harvest, right? And so when we look at all of these and we want to engage in that upstream approach to achieve health equity, really means we need to support those positive social determinants of health, social and economic opportunities, increased access to healthy foods. Our medicines, our sacred medicines, they're out there. Having safe physical activity spaces, access to health care. We had a really good conversation over lunch with some of the Mayo staff. What is that access to care for our relatives living in rural communities? Could say the same as we think about education, housing, modes of transportation, and access to the internet. And so much of our cultural and traditional ways can also help determine and increase our health for the better. And another key piece to really achieving that full health potential is breaking those cycles of trauma. This does include those protective factors such as cultural connectedness, a sense of belonging, resiliency, and practicing healthy coping skills. And as we nurture those stable relationships, right, and providing culturally tailored family education, connecting our families to community systems, resources, and providing spaces such as, where in a tribal health department or any department is there access to breastfeeding, things like that can really help us prevent some of those ACEs that I had talked about previous. And then finally, really incorporating a balanced lifestyle, which includes physical, mental, emotional, and spiritual balance. Are we then able to achieve that health equity and to help achieve that full health potential as Indigenous people and as an Indigenous communities? I want to take it a step further, right? And, at ACAF, we really, understand the need to assess our ways of life as Indigenous people, as an Indigenous organization, working to improve the health and wellness of our Indigenous communities. And we look at that when we start any new initiative. Our worldview as Indigenous people has always been nonlinear when compared to the Western worldview. And so in this Indigenous worldview, it's about interrelatedness, balance, and sustainability. our life ways are really rooted in culture and grounded in respect for all living things. Indigenous people are often collective in nature versus that individualistic manner. We think about collective cultures, we really emphasize family and work group goals above those individual needs. Whereas we think about some of that individual emphasis is really on that personal achievement, but, looking at that worldview as an Indigenous person, it's that community achievement. And so strengthening this connection creates opportunities for us to be healthier again as Indigenous people and to really build those partnerships grounded in this and to help bring that lens when we're working with non-Native entities. And again, using this to really guide our work, and we'll continue to use that to understand opportunities and use it for partnerships. And so as I was talking about those, those upstreams and those health equity, needing to understand that we need to assess our way of life as Indigenous people when starting any new initiative. And so again, looking at, keeping those unhealthy behaviors in the context of trauma, both historical and current, looking at those stressors, understanding historical genocide and colonization. And this one, living with the oppressor, unlike other marginalized communities, American Indian, Alaska Natives still remain on this land base and are regulated and owned in many ways by the federal government. And I've given, various trainings, and it's always, what is that context and what are we understanding about things in the past that impact the work that we do today and that we'll do tomorrow and in the future. Really looking at some of those government policies, systems, and environments and the impact that a lot of those have had. And so I won't necessarily go through all of these. I think it's good if you, do some research on your own and understand some of these, again, systems, policies. I'll just go over a few. We look at that Indian Reorganization Act, or the Relocation Act, when the Indian Relocation Act was enacted, there were 7 cities that were set up for American Indians to relocate from their tribal homelands so that they could be provide what the government thought was better jobs, better housing. The Bureau of Indian Affairs was there to provide temporary housing, counseling, guidance, and finding a job for those individuals that did leave the reservation and went to these 7 cities such as Minneapolis, Chicago, LA, New York, Seattle. And there were promises, that they were gonna have a job, they were gonna have a home, and eventually, those promises weren't kept. Those jobs were on the lowest income ladder. A lot of the individuals and families became homesick, but they didn't have the means to get home. And so again, this was another way to encourage American Indian Alaska Natives in the US to leave the reservation. Again, part of that Indian termination policy, which again wanted to terminate that tribal status of various groups across the nation. And really this Indian Relocation Act played a significant role increasing the population of urban Indians. And as you'll hear a lot that anywhere from 60 to 70% of American Indians now live in urban areas. In 1920, it wasn't until 1924 that American Indians were even granted US citizenship. And so even though they were granted US citizen, were considered citizens, it wasn't until 1965 that American Indians were able to vote, And we take that context and understand, World War II occurred from 1939 to 1945. So a lot of us have grandparents, great-grandparents that, were in the military and, were part of World War II, but they couldn't come home and vote. And even then, even though, we look at 1965, some states still did not allow American Indians to vote in various states. And so again, I talked about the government food system a little bit. A lot of American Indians know it as commodities. It's really been detrimental to American Indian Alaska Natives' health for years, and continues to, We were once, healthy and thriving. We had access to the land. We knew when to fish, and then to be, forced onto some of these reservations, we were no longer able to do a lot of that. And we were, a lot of them were given food rations, which, now are known as commodities. And so this diet has really led to a large number of our relatives having diabetes, heart disease, and cancer and other, health disparities. I'll just go over two more. The forced sterilization occurred from 1973 to 1976. And on record, again, this is on record, right? We can think about what wasn't recorded back then or what may have been lost. But, from that 3-year period, it has about 3,406 sterilizations on record for American Indian women. And so just, thinking about knowing as a woman, you go into the clinic, for an appointment to have a baby, to talk about something, and you come out sterilized. They often targeted full-blooded women. And I talk about this because one of the sites was Aberdeen, South Dakota, where, I was born in 79. And my older sister was born in 74. So I think about if my parents had lived in Aberdeen at that time and my mom used these services, like what were the chances that she would have been one of those 3,400 women? So again, understanding a lot of these policies today impact us and continue to. This picture is from Chairman George Gillette of 3 affiliated tribes in North Dakota. He was signing away 155,000 acres from the Fort Berthold Reservation so that the government could build the Garrison Dam. It caused more than 1,500 tribal members to relocate from that river bottom just so that they could build the Garrison Dam. And tribal leaders were really opposed to it and did their best to fight it. But eventually, so this photo circulates and it's out there, and there's a quote that goes with it with Chairman Gillette, and he says, "We will sign this contract with a heavy heart. With a few scratches of the pen, we will sell the best part of our reservation. Right now, the future doesn't look good to us." We see him crying, right? But I oftentimes tell attendees to look at the other 5 men. They just look disgusted, bored, want to move on. This is just another signature for them. And so really understanding the impact of building the Garrison Dam. And so we think about some of those other dams that are built on and near reservations. And of course, the boarding school era was one of the most devastating times for American Indian Alaska Natives and continues to impact today. And I'll talk a little bit about that in these next slides. Again, giving that context, right? Some of these historical events that were happening, and these are primary in the Midwest here, but also looking at what else was happening in the United States at this time, right? In 1869, the Transcontinental Railroad was completed. So we think about that expansion from east to west. 1874, gold was discovered in the Black Hills. The majority of that land was considered the Great Sioux Nation and eventually was broken up into tribes. In 1879, the boarding school era began in the United States. Only for 7 years later, the Statue of Liberty to be dedicated. So again, won't go into all of these, but I think, it's good and to see some of these and understand context of what else was happening as the United States began to expand and states were, dedicated. So I can also give a PDF of this to Karina to distribute. And so again, wanting, as we think about these partnerships and the importance of understanding that historical trauma is current trauma. The picture on the left shows 3 young boys who had, arrived at boarding school in the same photo, very different, same boys, but look at the posture, the clothing, it's just, different, and that's that boarding school impact. I also talk about, what does that mean to be current? In Canada, about, I'm going to say early 2021, it was first found that 215 remains of children were found at Kamloops boarding school in Canada. And that number keeps going up because they're starting to find more remains on some of these boarding school grounds. You know, a lot of them were grounded in Christianity too. So a lot of them had nuns and priests that were at these schools. And so looking at what was happening in Canada, Secretary Deb Haaland also, you know, wanted to do an investigation and understanding, you know, how many of our relatives and remains, you know, were buried in some of these schools without a name, without a, you know, understanding, you know, where they came from or letting the families know. And so in April of this year, that report was distributed. And I think within the US, there was right now the number in Canada is 1,400, but the number in the United States right now, when this report was released, shows 500 children in marked and unmarked burial sites across 53 of those boarding schools here in the United States. Again, we know that number is a lot higher. I don't think you'll meet a Native person that doesn't have a connection to a relative or a family member in the boarding school or that experienced boarding school. And so again, as we think about those, and you know, there's oftentimes I like to go into those and really, you know, dig deep and understand that. And hopefully you'll have time to do that, you know, more time to do that on your own, but really understanding that, you know, that health equity is crucial for the well-being and vibrancy of Native communities as we take into perspective all of those, you know, those traumas, those historical events that play a role in today, and how the importance of knowing that really can help entities, systems, even the government to build better relationships and partnerships with American Indian, Alaska Native communities. So knowing that, you know, health is a product of those social determinants and health disparities, and that health inequities really stem from some of that structural racism, discrimination, and poverty, and some, you know, that trauma from all of that. And so when we think about those solutions, again, you know, at the beginning, I talked about our Native communities have those solutions, they have the wisdom. And so leaning in again on that need to be tribally led, community-based, and rooted in culture when starting a partnership and wanting to understand each community, right? There's 574 tribal nations across the US. You know, again, each tribe is different. Each tribe has their own relationship with the government. So understanding a solution in one tribe may be totally different for another tribe. And again, understanding the impact of that trauma is necessary and needed, and, you know, can help just deepen that partnership as we move forward. Okay.
There we go.
Okay. And so again, you know, understanding all of that, right? That wisdom, that knowledge, that, you know, 574 tribal nations have sovereignty. You know, federally recognized tribes are recognized again as possessing certain inherent rights of self-government and are entitled to receive certain federal benefits, services, and protection, again, because of that special and that one-on-one relationship with the United States government. And so as we think about health equity, right, and understanding the trauma in each of those communities, it's really, you know, I think a time where utilizing that tribal sovereignty can really help advance health equity in our tribal communities. And we see a lot of them doing that, right? A lot of them are, you know, assessing the health and wellness of their community in the current state, and what are ways to get access to that data, you know, to advance that health equity, to make decisions, you know, to see where the partnerships are needed outside the reservation or even within the reservation. And so how can they really lean in on that tribal sovereignty to leverage positive change? And so I think it's just, you know, amazing to see that tribes have that opportunity and that they do govern themselves. And I think a lot of entities, you know, our partners don't understand that sovereignty sometimes, and that tribes, you know, govern themselves, whether it's the health department, the land, you know, understanding enrollment. Enrollment varies across our tribal nations. And I just wanted to remind us of trauma again.
Sorry.
Just kidding. And so all of that, right, leads to, again, understanding the importance of building partnerships. How can entities authentically partner with communities, with tribal nations? Again, trust the community has that wisdom, actualize positive change strategies that are conceived through community member engagement and conversation. A lot of times we'll see data that's harmful. Again, thinking about the data that you bring to a community and how you can really use that in a positive way versus, negatively, right? Seeing those numbers are harmful, if not hurting. And, we know, a lot of our communities know that, right? So again, how do we use the data to flip it, right? To create communities to use and even flip the current data and, what is positive within it and how do we use that to build engagements and conversations? One of my staff and I, have been building relationships for, I think we thought almost over 2 years now, if not close to 2 years with Mayo staff, right? And, it's been monthly calls and it's building to a project to really understanding the impact of COVID on cancer screenings within some of our communities here in Minnesota and hopefully some of these other states. To see them taking that time to talk with us as ACAF, right, to maybe help build that bridge between some of the tribal communities, is a sign of sustainability and that they are, Mayo is interested in wanting to increase the health and wellness of our Native people and those that they serve within the system. Again, looking at those organizational practices to meet the community where they are at, right? Seeing, what is available in that community, how many staff are within that clinic. Oftentimes, a lot of the Indian Health Service clinics are understaffed. So how can you bring in change without understanding what some of the organization or, looks like? And so being able to see that. And again, how do we cultivate that community-driven coalition to influence policy and practice? I think that's a time for a lot of us right now, even as Native entities, to really understand and rebuild some of our coalitions, from the pandemic. A lot of us, are burnt out, we're stretched thin on being on various coalitions, but we do it because our communities need it, right? And we want to help our communities. And so really, thinking about how do we use that to influence policy and then, use that for practice. I always have a joke at ACAF about, using data to influence our policy. So my research manager and our policy and prevention manager will kind of tease about it. So, always thinking about that and letting that, show that is really what we, our intentions are. And again, why these partnerships? What is the importance of it? And ultimately, what does it lead to, right? Recognizing, respecting, and honoring the tribal sovereignty of that one community you're working with. Taking it maybe to the next community, but also understanding that's a different relationship. Establishing long-term relationships, partnerships, right? Those have to be sustainable. They have to, finding ways and being creative in funding and projects to continue the work, right? We don't, a lot of our communities don't need 1 and 2 year projects. Even a 5-year project, isn't enough time to create sustainable change in a community. And again, just reiterating, centering those needs and priorities of the communities. Do they need this project right now? Is it something that's needing to be improved within the community? Have you seen the priorities of the community? And then you want to invest in them, right? Coming from that strengths-based approach. And again, giving continual support and resources. And, again, going back to that understanding historical context, what access and information do you have and where can we get more? Ultimately, again, the relationships really to get to reclaiming Indigenous health and healing with culture is where our communities need to be and want to be and are becoming and are getting there. And so as we think about that, those relationships, understanding historical context and what partnerships are out there, what entities can help create change, what does that path forward look like? Oh my God, this one looks duplicated. Wyatt's shaking his head at me. I did do this really early because I'm coming off a vacation. So I just got ahead of myself. Looking at creating sustainable change, you know, provider responsibility, you know, understanding, you know, helping clinic staff to really understand some of those barriers. You know, if we're working with a project that is working with clinic staff, you know, how can we really help educate them on what are some of those barriers to creating partnerships, or, you know, even a relationship with individuals or with a family. You know, how to get those building blocks there, you know, how do we build trust within a community, within a family? That takes time, right? Trust is not something that's just happens overnight, and it's something that is always, you know, in the works and can always be improved. And so how do we not only wanting to, you know, as ACAF come in and help, you know, build partnerships with some of these entities to create change in a tribal community, but, you know, what are those values and really understanding the clinic, the community, the individual, building trust within all of that, you know, to make change and understand those cultural norms. I think what are those tools in the toolbox we can really give to understand partnerships? And, you know, I think it varies on, you know, what the topic is or the project. If we're looking at cancer screening, prevention, or survivorship, you know, can all have different topics and areas, and I would love to go down all of those. Or we, you know, we even look at some of those personal experiences. Again, I think a lot of my staff come with experiences of seeing our loved ones go through a cancer diagnosis and what that journey is, and survivorship. And so again, understanding, you know, as we look at these changes, you know, what is those Western values versus Indigenous values? I always think about, you know, as many times as my dad's been in the hospital, you know, nurses would come in and they'd be like, oh, you know, what do you do for work? And it's like, you know, that's not important to Native people. You know, having a degree is amazing and it's something we'll talk about, you know, but we want to share our family with you. We want you to know where we come from. So even those little changes like that of, you know, helping providers and staff really know how to talk with patients, I think is just another tool in the toolbox. And how do we get down to those little things? You know, I know we can't do that in an hour presentation, but it's exciting to see that there are, you know, commitments and that we're seeing that change and those partnerships are being built. I talked a little bit about this again, that focus on change that encourages individual behavior, but coming from that collective lens as Indigenous people. And then again, what are those guiding principles for ways of living, right? Respect for elders, listening to understand. How many, you know, I think a lot of us could take that in, you know, just really sitting back and listening to the community before we even want to ask a question. You know, showing compassion, empathy, understanding where the community is at that moment. And I think we can think about that as prevention, right? You know, that wisdom, that knowledge of seeing where that is at, and, you know, just building on those three parts alone could, you know, bring cancer prevention. And again, you know, going back to that point of partnerships, understanding everything in this PowerPoint, right? You know, how do we increase those cancer screenings in Indian country? You know, bringing it back to increasing the health equity. You know, at ACAP, we really look at some of those cancer awareness campaigns that promote screening. And we do all of these in partnership with others, right? We couldn't do this work without, you know, community input. And so how we're building those culturally tailored resources, trainings and media tools, you know, is also input from the communities we've worked with. Again, community education and outreach. And again, how do we really collaborate with clinics to help build capacity and improve health systems? I, again, could go down this work. I love it. But I know we only have about 2 minutes before we get into Q&A. So I'll go really fast on these next ones, I promise. And so again, I love visuals. I tell my staff that all the time. And we look at some of these outcomes, right? These, again, not necessarily understanding partnerships, but these are just some of the resources we've created, you know, with folks in-house out of, wanting to get input and feedback, and if these tools and resources are needed in the community. So, also being reflective of our community members, right? So understanding women's screening and vaccination by age, what are the tools that actually go into a woman needing to get a PAP and breaking that down. I think sometimes we don't think about all those little steps and tools. And, again, what does it mean to be culturally tailored when we look at some of our resources? Here you'll see a lot of tribal words on the outside of this postcard that was created for the Oklahoma City Indian Clinic, right? These are the communities they've served on the outside. Again, more focus on some of that cervical cancer and PAP test. Screening prevention. This one, again, we just tailored that previous one, but this one was more for general use across Indian country. This was one of the first ones that some of my staff and I worked on about 3 years ago when a couple of us had first started. Again, check your Dudu Shiman. Minnesota's home to 7 Ojibwe tribes. So we made one in Ojibwe, which is Dudu Shiman breast. We also created a blank version that our communities could download and print and, ask their tribal members how you say breast in your language. This one is a recent one too, lung cancer screening, understanding what goes into that. Our research manager and I were really, was just hearing some of the misconceptions of what goes into an actual lung cancer screening. And how do we bring that back to our communities so that they have that information, or even to, health systems to really break that information down and understand the steps needed, for a lung cancer screening. So it's not intimidating. It doesn't seem scary. It's something that, why do we need this and what's the purpose? So I really like this one. It's very useful information. Again, and what does it mean to be culturally tailored and represent our communities? There's some of our COVID-19 resources, one on pregnancy, and again, just the overall importance of being a good relative. Why do we want folks to mask up? It's not only taking care of yourself, but others, your community, your elders. Some of our first COVID resources, understanding our lives are sacred. That is in our Hidatsa. And so again, understanding you can still get a colorectal cancer screening during the pandemic. I think this was probably created within 9 months of the pandemic starting, right? Wearing a mask on your age, but the clinic's responsibility in keeping you safe as well. More information on cancer and COVID, looking at the screening flow chart, guidelines, and what to expect. One partnership I just kind of want to end on. We did an amazing partnership last year with Red Earth Running Company for Sacred Breath Month, which is Lung Cancer Awareness Month. We did a virtual run and we're able to take the ACAP Eagle staff, which is something very sacred and important in Native culture, that was gifted to the organization from a cancer survivor. We took the staff out to New York City, and Dirk Whitebreast, one of the co-founders of Red Earth Running Company, ran with the Eagle staff for like 9-10 miles. It was amazing. We had only planned for him to have it for 1 or 2 miles, and he said he just felt it and he just kept running with it. So again, thinking about these partnerships. Last one, again, just highlighting the importance of the work we're starting to do with for our survivors. We got funding to create our first ever Cancer Survivorships Leadership Advisory Council. We also have a support circle on a monthly basis for survivors. June, we've really started to build up our Celebrate Indigenous Life campaign. And again, bringing these back to wanting to partner with others to help reach our survivors and really building kinship. More on our survivorship, again, just celebrating Indigenous life. Yeah, again, just so much information to share in this 1 hour on the importance of partnerships and building those to increase health equity and, eliminate cancer disparities in Indian country. So here's some ways to get a hold of us. Our website, we are on all social media channels. And I just, again, want to end with, as part of ACAP's commitment to our communities and health equity, we look forward to building relationships with community members and external partners in order to address intersecting cancer burdens. Again, we welcome you to reach out with questions and discussion about our living acknowledgements. Kitabi Pidama. Thank you.
Thank you, Melissa, for that wonderful presentation. So I'm going to open it up for any questions online or in the room.
Thank you. It was a great presentation, Melissa. And it was 2.5 years ago. It was April of 2020, just after COVID broke out, that you had called and regarding a lightning webinar and maybe speakers, because what we do about COVID then, and wanting to have a presenter to talk about the risk of people who were in remission or had active cancer. And I reached out to Dr. McWilliams, and that started our monthly, because we said, we can help with that, but let's not have it be transactional. Can we build a stronger relationship? And I learned something every time you present. And I also remember at one of our meetings, when you had brought up, and it was the first time that I had ever heard it, about the forced sterilization. And just even on the Zoom call, seeing my own face, the horror, and we emailed Dr. McWilliams afterwards and going, that trauma, and you spoke about it today, you weren't using those words then, that non-American Indians may not be aware of, and not realizing those barriers, because I took that very, as I was looking at going, that would be me not having my 2 children. I'm not that age, but I was close to that age that I could have been, because even they were teenagers. Some were 14 and 16 years old, and being told it could be reversed. Even I've read more about it. So going, that would have changed the whole trajectory of my life. And now would have been childless and no grandchild, the light of my life. But also, why would I go in for screening?
Right.
So I think we need to realize, and I don't know how to breach that gap, because we can do this in a room of 20 at a time, but the screening and prevention are key. And how do we get that? That's, I mean, I know we're trying and we're working, we're making small progress, but those are big barriers to overcome with some of the trauma. And it may not even be the women themselves who aren't getting the mammograms, but someone's sister or their wife or their, in their inner circle, that they remember that or something else. So I think that's something we on our side need to really work to make sure that we're educating so that we can understand what the barriers to that might be.
Yeah, and again, right, like, does it happen in a 1-hour Zoom, a 3-hour session? I think all of my staff have such amazing knowledge, and that personal experience as well. And, other entities across Indian country, but it takes really, and even I've been in this position or, doing this work, and I feel like I learned something new about how our trauma really impacts, going in for a screening, building trust with the healthcare system, or even having a conversation with a relative is not easy.
I think when we look at that linear progression of healthcare, even that if you're not considering these things, then you're thinking, oh, well, we'll offer mammograms, we'll educate about it, but that's very linear. Here's the processes of coming through.
Right.
Okay, we got one question online. Can you describe the ACAP relationship with Mayo right now? Is Mayo in the listening phase, or has joint work begun to form?
I was like, wait, what if I can't answer all of these? Yes, I would say we are in an amazing relationship with Mayo. Again, right, we are one entity. Mayo is one entity. We are doing our best to build a COVID project, understanding the barriers to cancer screenings. Actually have our research manager who's in the room if he wants to provide any, I'm going to put you on because I think there is movement, right? There has been commitment through a funded project for ACAP to do some of this work. And, it's taken time because of the pandemic. Communities don't have capacity to implement a project to them that seems maybe on the back burner, but for us to really understand what are these new barriers to that screening because of the pandemic and what has pushed back that scale or that circle. So
yeah, I would say, I think definitely the conversations that had started back in April of 2020 around COVID, but there was also questions of, how do we work together to help improve cancer screening rates? And we were looking to develop, I think, a colorectal cancer research project. And, when we went and engaged with our community partners, that just wasn't the priority, and trying to figure out how do we meet them where they're at. If they don't have the staff to provide, the emergency services and the care that's needed on a day-to-day basis, they're not going to be, interested in participating in a research project for something that may or may not happen. And so making sure that we, show up and provide multiple direct benefits. And I think that's what's really been great is partnering with Mayo, having multiple conversations, as we do this work and figuring out what the community needs are. And so I think we took a step back and developed this research project on the impact that COVID had on our communities, and starting from there and figuring out what are the resources and support that they need that forward. So we were talking on the way up here about developing these partnerships.
Mayo Clinic is committed to creating a safe environment for our patients and staff. To ensure everyone's safety, we require that patients, visitors, and staff
But
wear a
developing
face
really a
mask that
partnership,
properly
I think,
covers both your
the
nose
partnerships that
mouth
we have
while on Mayo Clinic
with
campus.
tribal
Thank you for your
communities,
help.
we go and we say, we're your partner, we'll help to identify projects and funding, because we know that those things come in and out, and we have to create those sustainable relationships. We're not going anywhere. We have to continue to provide that support for our communities, because they're going to continue to face, the issues regardless of if there's funding available. And so I think that's really a lot of the conversations we've been having with the Mayo staff of saying it's multiple things. It's not just screenings, it's not just treatment. We have to have a comprehensive approach and figuring out where the gaps are and helping to fill those.
Yeah. Any other questions in the room? Are there any online?
It was just a comment online. Dr. Taylor Desir had commented that she appreciated you reviewing the history and the impact that it has on health today.
The importance of the long game and sustained relationships. And as all of us go to different roles and maybe different institutions or retire, what do we build for that long term? What would be your thoughts on building that long-term relationship so we have that entrenched sustainability?
I think there's multiple people in the room that can answer that, but I think about, again, just the importance of relationship building, right? It's not just you give me this and it's done, right? It's, again, knowing that this relationship is not going to end, and whether I see you in this capacity at Mayo or with ACAP or a different one, like I intend to keep these relationships for the benefit of our tribal communities, right? To me, it doesn't end. It's maybe just in a new phase or a different capacity, whether it's today or tomorrow or 10 years from now. I just really value relationships. And I think sometimes we forget how much it is to just sit and have a conversation before you even get to that. This is our problem. It's like why I said you take those steps back and just get to know each other. Then some of that work comes out, or maybe the priority shifts are once you get to know each other in that relationship. Like,
I'll just add, I think, even I think building off of that, of humanizing the work that we do, and that this isn't just like a job or our profession, but making it more relational. In the work that I do in research, I don't perceive data points as data points. I remember that those are whole people with, an entire story behind them, a whole life experience that goes into that. And so remembering that, these data that we work with and the partnerships that we build really reflects the communities and our relatives that we do this work for. So I think that has a big part of it, of like working to understand and remember that like we can be relational and, like you were saying earlier, not transactional. And I think that's really where it starts, especially in trying to work towards addressing a lot of that mistrust within healthcare systems.
Great. Well, thank you all. Thank you again so much for that presentation. We really appreciate you coming down to be with us in person. And always happy to work with you all. Thankful for the partnership that we do have. And thank you everyone who has attended online and in person. I just want to let you all know that this has been recorded and we will be posted on our website, as well as our next presentation will be coming September 22nd from 12 to 1 Central Standard Time. And that will be, there'll be emails coming out. We do have an evaluation form that will also be going out in a few days. So please fill that out and give us your feedback so we can continue to improve these presentations. All right, well, thank you, everyone.